Thank you, Mr. Chairman. It's an honor always to be with our distinguished professors in نفرو أليكس اسكندرية الجميلة اللي كلنا بنحبها. أنا المحاضرة الحقيقة يعني الدكتور أيمن خلى الموضوع يبقى أسهل لأن هيبقى فيه اوفرلاب كبير ما بين المحاضرتين. كلام هيبقى عن when to stop treatment in failed graft. Over the last few decades, the long-term survival of kidney allografts has significantly increased. برغم كده, a substantial number of kidney transplant recipients eventually require the permanent reinstitution of kidney replacement therapy because of allograft failure. The survival of such patients on dialysis appears to be relatively poor, and the risk of death is significantly higher with allograft failure versus those with continued allograft function. And one of the most common or important aspects of managing the patients with a failing graft is deciding when and how to safely stop maintenance immunosuppressive therapy. So for the management of immunosuppression, in general, the primary goal is to withdraw the immunosuppressive agents without precipitating rejection, causing any adverse effects related to drug withdrawal or exacerbating allosensitization. Secondly, the impact of sensitization should be considered for those patients pursuing another transplant, and continuation of immunosuppression might be necessary in patients who are felt to be too frail, زي ما كان المحاضرة بتاع الدكتور هاني, to tolerate a transplant nephrectomy, which is major operation. These are one of the frailties اللي بنتكلمنا عنها دكتور هاني. Reasons for withdrawal of immunosuppression. ليه هنعمل withdrawal؟ طبعا the most compelling reason to withdraw immunosuppression medication in dialysis patients with a failed kidney transplant is infection, malignancy, and complications associated with long-term immunosuppressive use. Infection is the second leading cause of death in this setting, and the dosing of some immunosuppressive agents may be challenging in patients on hemodialysis or those who reached kidney failure and they have to and they are still on immunosuppression. Increased risk of infection. طبعا risk of serious infections is observed in both transplant recipients because of the direct effect of immunosuppression and dialysis patients. And the dialysis نفسه is an immunosuppressive state. Uremia is a cause of immunosuppression. These factors contribute to the remarkably high incidence of infection in dialysis patients who continue to receive immunosuppressive medications after a kidney allograft has failed. This is particularly concerning in the failed transplant patient utilizing venous catheter or hemodialysis catheters, اللي ده هيبقى another source of infection في عيان already immunocompromised. Increased risk of malignancy. Although the incidence of cancers after allograft failure in kidney transplant recipients was highly variable, the incidence of Kaposi sarcoma with non-Hodgkin lymphoma decreased markedly on reinstitution of dialysis, as did the incidence of lip cancer and melanoma, لأن احنا بنقلل immunosuppression أو بنوقف. The decreased risk was generally observed for cancers associated with viral associations زي الكابوسي sarcoma or non-Hodgkin lymphoma. The decreased risk of lip cancer may have been due to association of human papilloma virus and skin cancers. Melanoma صحيح ما فيش known infectious etiology ليها, لكن there is a causal relationship between immunosuppression and its development was suggested. Complications of glucocorticoids were shown beautifully by Dr. Ayman. هنقول بسرعة, patients on long-term glucocorticoid therapy are at risk for infectious as well as non-infectious complications, including osteoporosis, muscle wasting, cataracts, and hyperglycemia. Altered drug dosing دي حاجة مهمة قوي, إنه several of the standard immunosuppressive agents have special considerations in patients with severe kidney function impairment. زي الكالسينيورين inhibitors which are not metabolized صحيح by the kidney ولا excreted by the kidney, still their neurotoxicity may compound the neurological effects of uremia. Kidney failure can result in changes in the pharmacokinetics of mycophenolates which may result in higher blood levels of active drug. ودلوقتي بقى عندنا tool ان احنا نقيس بيها الليفل بتاع ال MMF وال MPAs, so it's something to be considered if you have such patient. So the approaches for withdrawal of immunosuppression, there is no high quality evidence to guide the optimal method for tapering or withdrawing immunosuppression following kidney allograft failure. لكن عموما بنحط two categories. The first one is the early graft failure اللي هو within the first year post transplant. In those patients, if the center will adopt a preemptive nephrectomy policy or immediate withdrawal immunosuppression at the time of nephrectomy. يعني for those patients نعمل preemptive nephrectomy and withdraw immunosuppression. لكن في الحيانين اللي بقى لهم اكتر من 1 year late graft failure, in those patients with later allograft failure approach differs depending upon whether or not the patient is likely to receive another kidney transplant within 1 year. If the patient was planned for retransplantation خلال سنة من failure of the graft, for most patients with late graft failure اللي هيخش في القصة دي هنعمل withdrawal of the antimetabolite immediately, reduce the calcineurin inhibitor dose بحيث انك تكيب prograf or FK level between 2 to 5 nanogram per ml, or if he was on cyclosporin to keep a trough level between 50 and 75 nanogram per ml, and continue till the time of retransplantation. And continue prednisolone at 5 milligram per day until the time of transplantation. If there was no plan for retransplantation, or it is not planned within the near future, within the coming year, in those patients who are, such patients who are not planned for this transplantation, the approach depends upon the residual kidney function of the patient. Kidney allograft function tends to deteriorate rapidly after withdrawal of immunosuppression in dialysis patients طبعا. Thus, in patients who continue to have good urine output, a longer tapering of the immunosuppression may help to maintain some allograft function. هيساعدوك شويه ان العيان ما يبقاش overloaded, عنده شويه يورين يقدر ما نحتاجش انه نديله فرصه يشرب اكتر شويه, ما نبقاش خايفين من الاوفرلود. So في كل الاحوال we withdraw the anti-metabolite, we reduce the calcineurin inhibitor dose to once daily بنفس الجرعه اللي احنا قلنا عليها المره دي هتبقى once daily, وهنخليه يبقى الليفل برضو من 2 في الاف كي من 2 ل 5 نانو جرام, وفي السايكلوسبورين من 50 ل 75 نانو جرام. Subsequent tapering is as follows. In patients who continue to produce urine, urine output بتاعهم أكتر من 400 milliliter per day, taper the dose of CNI slowly over the 6 to 12 months until the drug is discontinued. However, the duration of the tapering should be adjusted based upon re-evaluation of the patient's residual kidney function. لأنه كان 400 ممكن مع الوقت بدأ يقل, ممكن نسرع التابرينج. In patients who are oliguric, يعني أقل من 400 milliliter per day, generally taper the dose over 3 to 6 months until the drug is discontinued. And if the patient is frail and unlikely to tolerate transplant nephrectomy if needed within the next few months, we defer tapering the CNI until the patient overall physical condition improves to avoid the risk of precipitating immediate rejection عشان يقدر يخش العملية ويعمل نفركتومي لو العيان ده هنعمله نفركتومي. البريدنيزولون أو البريدنيزون في الحالة دي we taper by 1 milligram per month until the drug is discontinued. If the patient is starting with a maintenance dose of prednisone أكتر من 5 milligram per day, بننزل directly لل 5 milligram immediately, and then we taper by 1 milligram per month زي ما قلنا من شوية. ده الدياجرام أو الالجوريثم بتاع التيبرنج اللي احنا اتكلمنا عنه. I will skip it for the sake of time. So, monitoring during withdrawal of immunosuppression. All patients who are undergoing withdrawal of their immunosuppression should be closely monitored for complications of withdrawal, including rejection and secondary adrenal insufficiency. The continued administration of immunosuppressive medications to patients with kidney allograft failure would at first glance appear to be unnecessary, since such agents increase the risk of infection without providing obvious benefits. Withdrawal of immunosuppression may be associated with significant complications, precipitation of rejection, possibly requiring transplant nephrectomy, secondary adrenal insufficiency, loss of residual kidney function, adverse immunologic effects among those pursuing another transplantation, and worsening anemia due to erythropoiesis-stimulating agents resistance. Precipitation of rejection in patients who develop rejection during withdrawal of immunosuppression, we will administer a 5 to 7 day course of prednisone at a dose of 0.3 to 1 milligram per kg per day. Patients are subsequently referred for nephrectomy, and some centers will attempt to embolization of the allograft prior to or in preparation for nephrectomy. And by comparison, some nephrologists advocate immediate nephrectomy for those with even mild symptoms of rejection after immunosuppression agent withdrawal. If secondary adrenal insufficiency happened, dialysis patients with secondary adrenal insufficiency frequently present with subtle findings of isolated glucocorticoid insufficiency, including persistent fever, weakness, fatigability, myalgias, arthralgias, weight loss with subsequent fluid overload due to lack of adequate ultrafiltration, mild hypercalcemia, and eosinophilia. In cases such as this, administer low dose of prednisolone من 0.05 to 0.1 milligram per kg per day to see if symptoms improves. And then if symptoms improve, attempt a slower prednisolone tapering. Thus, although the ACTH stimulation test is the gold standard في حالات adrenocortical insufficiency secondary يعني, but it still remains to be established. لكن الحقيقه الثيرابيوتيك test of giving steroids وملاحظه ان العيان تحسن is much more valuable in such patients. In general, the length of time required to recover normal hypothalamic pituitary adrenal function depends upon the degree of suppression. This in turn depends upon the dose and duration of the glucocorticoid immunosuppressive therapy. The time varies from few weeks to as long as 9 months or more, since the findings of adrenal insufficiency in those patients are subtle, conservative clinical judgment with careful laboratory evaluation should be employed. Examples is patients who tolerate glucocorticoid withdrawal under non-stressful conditions require a temporary increase in glucocorticoid dose during stress. طيب indications of for nephrectomy بسرعه برضو دكتور ايمن عدى عليها هنعدي برضو بسرعه. The most common indications for transplant nephrectomy are the onset of symptoms and or complications related to rejection after withdrawal of immunosuppression and history of early graft failure with or without symptoms and or complications. السيمبتومز اللي احنا عارفينها الجرافت tenderness, fever, hematuria, localized edema, occasional infection, less fulminant rejection may present with unusual symptoms like weight loss, anemia, fatigue, etc. Patients who have early graft failure are much more likely to develop a graft-related complications requiring nephrectomy than those اللي حصل لهم late graft failure. The abrupt withdrawal of immunosuppression among those with early graft failure increase the risk of precipitating rejection attack, severe rejection attack. Morbidity and mortality from nephrectomy has improved markedly, so most centers to adopt a policy of immediate withdrawal of immunosuppression combined with preemptive nephrectomy for patients with early graft failure. طيب الاوتكم افتر nephrectomy البيشنت سرفايفل هتلاقي فيه هنا controversy. بعض السنترز قالت ان the patient survival improves after nephrectomy. في سنترز ثانيه قالت بالعكس patient survival is does not change. وبعضهم قالوا انه actually it is reduced after nephrectomy. ما فيش يعني كلام اكيد في الليترشر عن الموضوع ده. الثلاث اراء اتقالوا. طبعا في surgical mortality and morbidity، بس طبعا in good hands وعيان مش فريل ومتحضر كويس احنا نقدر avoid most of these. طبعا بيحصل intestinal ischemia, intravascular coagulation, bleeding, hematoma, etc. infection، كل دي حاجات ممكن تحصل. The effects on sensitization. Several small studies have showed that transplant nephrectomy associated with human leukocytic antigen antibody sensitization. These studies suggested that it is not advisable to routinely perform a transplant nephrectomy after graft failure. وكان دكتور رشاد دايما يقول ان الكلى دي عامله زي السبونج بتاخد الانتي بوديز جواها، فيعني هو كان مش مع التحفيق، يعني بيحبذ النفركتومي. Immediate withdrawal of immunosuppression is associated with an increased need for transplant nephrectomy, which is associated with HLA sensitization. It is not clear whether long-term continuation of immunosuppression prevents sensitization in patients who are being considered for retransplantation أو لأ. مفيش برضو evidence على كده. Effects on retransplantation. An unresolved issue is whether there might be some benefit for retransplantation from leaving the failed graft in place. In humans, however, there appears to be no clinically significant difference ما بين ان احنا نسيب الجرافت لما نيجي نزرع تاني او نعمل نفركتومي بعدين نزرع. ما فيش في الستاديز اكدت حاجه زي كده. Despite the retrospective findings linking nephrectomy and sensitization, there is no proven causal relationship between nephrectomy and subsequent high PRA levels. Non-surgical alternatives. Although nephrectomy طبعا هو الكونفنشنال، لكن زي ما قلنا في محاولات بتاع الامبولايزيشن، vascular embolization، ويعني reported في بعض الاماكن. Dialysis after graft failure. Patients may require dialysis after their transplant kidneys has failed. This may occur many years after the transplantation. The indications for initiation هي زيها زي initiation لأي عيان renal failure عادي. Earlier attention to markers for graft failure to initiate CKD planning may improve outcomes زي proteinuria, decrease in kidney function of more than 30%, and recurrent disease or transplant glomerulopathy عشان تجهز عيانك انه يعمل زرع تاني، تعمله فيستولا etc. Dialysis modality برضو الoptimal dialysis modality after allograft loss is unclear، لكن زي العيان العادي اللي عنده renal failure. Prognosis. Patients who return dialysis after graft loss have a high mortality rate even when compared with dialysis patients who have never received graft before. Retransplantation. It is suggested to offer preemptive transplantation for most patients after the first transplant kidney has failed. This is consistent with British Transplant Society guidelines في 2014. The one exception is when the first transplant kidney has failed within 1 year. In such patients, we suggest a short period of dialysis أسبوع إلى 4 أسابيع، يعني مش prior to transplantation rather than preemptive transplantation. في حاجه اسمها failed allograft syndrome. The early diagnosis of the graft intolerance syndrome or a subclinical state of chronic inflammation due to a failed kidney allograft is one of the goals that the nephrologist must fulfill. بيحصل fever, hematuria, local pain, tenderness. These are the main symptoms. However, there are not any clinical symptoms and only the presence of parameters of chronic inflammation زي CRB و ESR ممكن يكونوا هم الفايندينج الوحيد. طبعا maintenance of immunosuppression treatment is not advisable due to the risk of infection. Transplant nephrectomy is the best treatment if there are some associated complications. ويعني هو ده كان آخر conclusion. ممكن خلاص كده. Thank you.